Bismillahir Rahmanir Rahim. Assalamu alaikum. I am Professor Adam Ahmed Adam. You are welcome to this parasitology lecture about schistosomiasis. Schistosomiasis is a parasitic disease also known as bilharziasis. It is caused by the trinematode worm Schistosoma species. Humans were affected by this disease since the ancient time. A case was discovered in the year 2014 belonging to a child with schistosomiasis dated back to 6,200 years. Schistosoma species are trematodes where sexes are separate. They are male and female schistosoma worms. Schistosoma species infecting man-causing schistosomiasis are Schistosoma mansoni, Schistosoma hematobium, and Schistosoma japonicum. Still, there are other Schistosoma species of limited distribution, such as Schistosoma intercalatum and Schistosoma mekongi. Schistosomiasis as a disease is classified into two types according to the anatomical site affected: intestinal schistosomiasis and urinary schistosomiasis. Intestinal schistosomiasis affects the large intestine and it is caused by Schistosoma mansoni and Schistosoma japonicum, while urinary schistosomiasis affects the urinary bladder and it is caused by Schistosoma hematobium. Occasionally, Schistosoma species may cross-reside. And by this I mean, in rare occasion you may find Schistosoma hematobium in the large intestine and Schistosoma mansoni or japonicum in the urinary bladder. Then we come to the topic of intestinal schistosomiasis. As I have just mentioned, it is caused by Schistosoma mansoni and Schistosoma japonicum. The intermediate host are freshwater snails. For Schistosoma mansoni, it is the Biomphalaria snail. I would like to remind you here that the snail is a spongy creature inside the shell. The shell is the protective shelter. And so you see here, the snail is protruding or coming out of the shell. For Schistosoma japonicum, the intermediate host is the Oncomelania snail. And we see here just the shells of Oncomelania snails. The infected stage is a cercaria. Cercaria is an aquatic stage which comes out or shed from the snail. It swims in water, and if a person comes in contact with water, it moves rapidly towards him or her to infect by skin penetration. The main pathogenic stage is the egg. Egg is the cause of chronic schistosomiasis. And you see here, the egg in the upper part is the egg of Schistosoma mansoni, and the one below it is the egg of Schistosoma japonicum. A question: When humans contaminate water with eggs, the answer is when patients with intestinal schistosomiasis excreting eggs in their stool defecate in water. And here the pictures will tell you. The environment of infection. Uh, the environment of infection is a slowly running fresh water, being natural or man-made. So the infection takes place here. And this probably a natural environment of infection, and also probably this is a man-made environment of infection. In all of them, I put pictures of uh, several cercari to remind you that the infection takes place here. The life cycle. There are two types of life cycle. Sexual life cycle in man. When I say man, I mean male and female, men and women. And asexual life cycle in water. Let us start the life cycle. We begin with the point of human infection here in number one. When a person comes in contact with water, the swimming cercari will move rapidly towards him or her, and they penetrate the skin. So cercari penetrate human skin and lose their tails and become schistosomula. Schistosomula is or are cercari without tails. When they shed their tails outside the skin, they become schistosomula. And you see and compare here. Below the horizontal line are the cercari, and above it, the schistosomula. And so once again, cercari penetrate human skin and lose their tails and become schistosomula. In number two, the schistosomula penetrate the veins and are carried in the blood to the heart, then to the lungs, and back to the heart, and at the end to the liver. You see here in number three, they mature into adult worms in the portal circulation in the liver. So we have mature uh, worms, males and females. In number four, each male couples with the female, and this is the coupling. You see here the stout, the thick, the huge one is the male, while the slender, the thin one is the female. And the coupling is by that the male accommodates the female in a groove known as gynecophoric groove. the the female is accommodated in the gynecophoric groove in the male. So they go in pair like this. And after coupling, they travel to the large intestinal or intestine venous plexus, the small veins in the wall of the large intestine, especially the rectum. There they mate, and females lay eggs. The female schistosoma mansoni lays about 350 eggs per day, and the female schistosoma japonicum lays about 2,000 eggs per day. Some of the eggs are passed in stool. If the stool is passed in water, eggs hatch releasing miracidia. And the miracidia coming out of the hatching eggs are rapidly swimming stages seeking or looking for the intermediate host. Here in number 7, miracidia penetrate the snail and develop to produce cercari at the end. There are many stages in between, but at the end, the product, uh, the cercari. In number 8, cercari emerge from the snail and swim in water. And now, the cercari are ready to infect a person if he or she comes in contact with water. Point about cercaria. Cercaria is a singular of cercari. Cercaria survives in water for 10 to 40 hours according to the environmental conditions. Again, this is a picture of the adult male and female. They are in they are couple here, and you see that the female is a bit longer than the male, but thin. The duration of time from infection to maturation ranges from 5 to 7 weeks, and the worms can live in the blood vessels for 3 to 10 years. Now we come to the fate of the laid eggs. As I have mentioned just now in the life cycle, some of the eggs passed in stool, and we here would like to see where the eggs go. Part will be excreted in the stool. So number 1, excretion in stool. 2, retention in the large intestinal wall. Some eggs are retained in the large intestinal wall. The other eggs remainder are washed back to the liver in the venous return, in the venous circulation. They go to the liver, to the portal circulation. Here in number 4, I'd like to mention a point. When the schistosomes reach the anorectal plexus, the laid eggs may enter the systemic circulation and be lodged in the lung. In the lung, they lead to pulmonary arterial hypertension or pulmonary hypertension. The anorectal region is the region where you find portosystemic junction or portocaval junction in the blood vessels. The pathogenesis, the main pathology is mediated by the eggs. The eggs mediate the chronic schistosomiasis. The penetrating cercaria can lead to local inflammation. When cercaria or cercariae penetrate the skin, there will be local inflammation and itching, and this is known as a swimmer itch. Katayama syndrome, the migrating schistosomia will lead to hypersensitivity reaction, allergic reaction, which is mainly type 3 hypersensitivity reaction like serum sickness, the swimmer itch and Katayama syndrome constitute the acute schistosomiasis, while the uh, eggs mediate the chronic schistosomiasis. In the rectum, the retained eggs lead to granulomatous mass, granulomatous reaction, or polyp. This mass is known as bilharzioma. It is a harmless condition, but maybe misdiagnosed clinically as carcinoma. So to resolve the doubt, you take a biopsy and you process it histologically to see what is there. The bilharzioma will appear like this: egg granuloma. So here you see the arrow is pointing to the egg, and around it the granulomatous reaction. In the liver, the deposited eggs in the portal tract lead to periportal fibrosis. Simmer pipe stem fibrosis as being called. This will this fibrosis ends up into portal hypertension. There will be increase in the portal blood pressure. The clinical manifestations, signs, and symptoms from the start of the disease to the end. There will be bleeding per rectum, swimmer itch, Katayama syndrome, and the patient may present with complications. The complications: portal hypertension. This leads to hepatosplenomegaly, increase in size of the liver and the spleen, and there may be excessive fluid in the peritoneal space. This is known as ascites. And you see here, this patient in the front has huge abdomen due to hepatosplenomegaly and ascites. And also the one at the back, but at the beginning, still not reaching this stage. Opening of portacaval or porta systemic junction. And this is opening up of the area, the junctional areas that are communicating the systemic circulation and the portal circulation during the intrauterine life. They close up after delivery. But in case of portal hypertension, they open up, and the blood vessels there can bleed, especially in the lower esophagus. And this area is known as the area of esophageal varices. So here, the patient may bleed torrentially, hematemesis, vomiting blood, very huge amount of blood. And if the patient is not promptly treated, he or she may die. Neuroschistosomiasis. When the eggs reach the central nervous system, being the brain or the spinal cord, they initiate inflammatory reactions. And as you know, the central nervous system does not accept extra volume or any fibrotic or granulomatous reaction, and the patient will present with neurological manifestations. Uh, Here at the end, pulmonary hypertension. When the eggs reach the lungs, they initiate inflammatory reaction leading to fibrosis and narrowing of the blood vessels, raising the vascular resistance, and the right ventricle will find difficulty in pushing the blood to the lung. Acutely, it may distend, and chronically, it may hypertrophy. And at the end, there may be right ventricular failure, and this is known as cor pulmonale. Clinical or diagnosis, clinical assessment, and then laboratory investigation by taking the stool specimen. And the stool specimen can be concentrated by different types of concentration. And the best one is the CAT test. And then microscopic detection of eggs in stool specimen. And the egg of Schistosoma mansoni has got lateral spine. You see here the spine in the upper part, that protrusion. And the egg of Schistosoma japonicum has got rudimentary spine, that is to say, an extremely small spine. Treatment, the best drug used to kill the worms, the adult worms, is the praziquantel. It is given in a dose of 40 milligram per kilogram of body weight in a single oral dose. Prevention is by breaking of the life cycle. I think this is can be a complete topic, and the life cycle can be cut in several points. The aim of treatment is patient cure. You'd like the patient to be cured from the disease. So you give the drug and you ask the patient to come for follow-up some 4 to 5, 6 weeks later. And after he or she comes, you do clinical assessment, and then you examine the stool for eggs or ova. Probably the stool may be free, but if it happens that you find eggs in stool, you have to test where these eggs are alive or dead to make sure that uh, the patient is cured. So how to know that the eggs are alive or dead? By microscopic detection of flaming bodies. While you are examining the eggs, viable eggs show flaming bodies, blinking and winking bodies inside the eggs, indication of viable eggs. To resolve the doubt completely by doing hatching test. The hatching test, presence or absence of miracidia. How can this be done? You emulsify part of the stool specimen containing eggs in fresh water, and you put that in glass container, and you expose it to sun or to artificial light. So the source of light can be natural or artificial for 2 hours. And after that, you examine the surface of water with a magnifying hands lens looking for the motile miracidia. If you do not see any motile miracidium, this means that the eggs are dead. But if you see motile miracidia, this means that the eggs are viable and there are viable worms in the patient. I hope that this point is clear. By this, the lecture is over, and I hope that it is understandable, and I wish you all the best.